In this capture, we're going to begin to look at some neurologic disorders, specifically multiple sclerosis and myasthenia gravis. Starting with MS, multiple sclerosis. It's a progressive autoimmune disorder. And basically it causes the development of plaques on the myelin sheath on your neurons. And that plaque interferes with impulse transmissions in the central nervous system. So what this means is your patient's going to have some impaired motor function. They're going to have issues with their gait and balance. They're going to be unsteady, and they're going to have issues with muscle strength. They often experience muscle weakness. Initially, the symptoms of MS are very vague. It often starts with some episodes of diplopia or double vision, but then it goes away. So the symptoms are very vague. How many of us have not had blurred vision when, we've been tired or something else is going on? And because it's so vague, it often delays diagnosis. Once a patient's actually diagnosed, if you go back and look at their symptom history, they're usually having symptoms for several years before it's officially diagnosed. Risk factors include being female, sorry gals, 20 to 40 years of age, and there does appear to be a family or genetic link. There are different types of multiple sclerosis that differ in their disease progression. There's relapsing remitting, where your patient has exacerbations, and with each exacerbation, symptoms, they don't completely recover, and progressively they get worse. There's some that are primary progressive, where they just, consistently are getting worse. So there's different types, and the prognosis is going to vary based on the type and the individual. The biggest thing to keep in mind about MS is that it is a chronic condition, and your patient is going to have symptoms, but they will have flare-ups of their symptoms. So we call that relapse or an exacerbation. And there are certain things that are going to trigger these exacerbations. So it's important that you're familiar with them, and it's important that your patient is familiar with them, because a key aspect of managing multiple sclerosis is going to be avoiding or minimizing these triggers. You want to try to prevent a relapse, prevent an exacerbation. So any type of infection, whether it be viral, bacterial, fungal, that's going to put them at risk for a exacerbation. Body temperature extremes. So if they're really cold or they're really hot, running a fever, that can trigger a flare-up. Being in a hot shower or a hot bath, hot tub, sounds really good to us, not so good for your MS patient. It can really cause a flare-up of their symptoms. The climate and their surroundings, a very cold or a very hot, humid environment can trigger flare-ups. Physical stress and overexertion with exercise, that can be a trigger. Emotional stress can cause issues, and as well as the changes in hormones involved in pregnancy. We often see females who have MS and get pregnant, they may have an increase in their symptoms. So what are you actually going to see in this patient? Fatigue for sure. They'll have muscle weakness, they'll be fatigued, particularly in the lower extremities. They may also experience paresthesia, where they're having numbness and tingling, or even some pain. They're going to have ataxia, issues with walking, and this relates to the muscle weakness, and they may also develop some muscle spasticity. Nystagmus. So when you check their cardinal fields of gaze, when you're doing your neurological assessment, the eyes should move in conjunction with each other, and it should be a nice smooth movement. Where the nystagmus, you'll have that little twitching back and forth of the eye. They may have diplopia or double vision. They may have reduced peripheral vision, and they may see a change in their visual acuity, where they actually use the Snellen chart and look at that visual acuity. Tinnitus is common, as well as vertigo, and they may have issues with hearing. As the disease progresses, they may develop issues with dysphagia and swallowing, so we worry about potential for aspiration. Dysarthria, it's not uncommon. They tend to have like a slightly slurred, but more of a nasal tone speech. So, you kind of think about how you sound when you have that nasal congestion. They may show some symptoms of bowel dysfunction. It could be constipation or fecal incontinence, as well as bladder dysfunction. It could be things from urgency all the way up to retention, where they require self-catheterization. Longer term, you may see some memory loss and impaired judgment, and there is often sexual dysfunction that is involved as well in the later progression. Something to keep in mind, and it's referred to as Uthoff's sign, and this can really confirm a diagnosis too. You'll see a temporary worsening of symptoms after exertion or after they're exposed to heat. So again, that's Uthoff's sign. The biggest thing to keep in mind is that it's a chronic disease, and as of right now, there is no cure. So our treatment is really aimed at slowing disease progression and managing the symptoms. So when you think about the medications for MS, you look at those different aspects. So for long-term disease treatment, where we're trying to slow the disease process and we're trying to prevent, reduce, and treat exacerbations, we will use things such as immunosuppressants, because it goes back to the concept of the immune system is going haywire and it's attacking the myelin sheath on the neurons. Okay, so if we can get the immune system chilled out a little bit and it's not attacking, that's going to slow down that damage. So we do that with immunosuppressants, immunomodulators, interferons. Things to keep in mind, we're suppressing the immune system because we don't want it to go haywire. But on the flip side, if we suppress it too much, that can put them at risk for infection. So we do need to be watching their blood work. We'll look at the CBC periodically. We'll look at liver function tests, okay? Specifically because these medications are typically metabolized by the liver. We want to keep an eye on that. It also can affect their thyroid, so we want to look at TSH and free T4 testing periodically. Your interferons may also cause some flu-like symptom side effects, so it's not uncommon for us to pre-dose them with acetaminophen or ibuprofen an hour before, and for them to take an additional 1 or 2 doses post-treatment. Okay, so that's more for your long-term disease treatment. If they're having an acute exacerbation, we're going to use IV corticosteroids. Typically, we'll use methylprednisolone, also known as Solumedrol, in higher doses. We'll taper that down back to a low dose, but that's just to suppress that acute inflammation that's causing the flare-up. And then from a symptom management perspective, we'll use antispasmodic medications to help with the muscle spasms, that spasticity. We may use anticonvulsants. You think about, wow, those are used for seizures. We actually use them to control the nerve impulses that may be contributing to the paresthesias that your patient is experiencing. From a bowel perspective, we often use stool softeners and laxatives. We may use anticholinergic medications and beta blockers or benzos to treat some of the tremors that they may have in that spasticity. Again, our overall goal is to slow disease progression, prevent exacerbations, but really for them to maintain as much independent function as possible. In the later stages, you may see some cognitive decline. So to address that, we want to frequently reorient the patient. We may use memory aids, so whiteboards, writing things down, calendars, and really trying to establish a daily routine and structure and sticking with that. Those techniques are similar to things that we do for patients with Parkinson's, patients with dementia, and Alzheimer's. From a communication standpoint, if they're having difficulty communicating, like the words, you can't understand them, We may need to look at using a communication board, which has pictures that they can point to, indicating what they need. Keep in mind that talking, especially extensive talking, may cause some fatigue. For visual deficits and the diplopia, they can alternate eye patches. That's been kind of shown to help. If we patch the right eye for a while, a day or so, then patch the left, that seems to help a little bit. But the other thing is teaching them to scan their environment, actually moving their head from side to side, that they're able to scan and see their entire environment. Balancing rest and exercise is going to be critical for this patient. They already experience weakness, so we want to keep that manageable. We do want them to exercise. We do want them to stretch their muscles. Okay, yoga is a great thing. Stretching exercises are a great thing for your MS patients, but they have to avoid fatigue, overdoing it, and they want to avoid overheating. So they really need to be exercising and stretching in a climate-controlled environment. So you think about air conditioning, that's not too cold, but it's managing the humidity. Other things important, using energy conservation measures, kind of group your care together, plan for frequent rest periods. Management of an MS patient requires the collaborative team. They're going to need assistance with physical therapy and occupational therapy. Depending on how things progress, living environments, they may need some modifications to the home. As they begin using adaptive equipment, as they begin using assisted devices, walkers, potentially eventually a wheelchair. Modifications to the living environment, sometimes a completely different living environment, they may need skilled care. So things to think about with that collaborative team. Thinking about bowel and bladder control, making sure we have medications to address that, but trying to get them on a voiding schedule of emptying their bladder. They may require intermittent catheterization, and if that's the case, they're taught to do that procedure, or a family member is taught to do that procedure in the home. Do keep in mind the difference between catheterizing somebody in a facility or institution versus home catheterization in the sterile versus clean technique. We can use the Crede maneuver, and that is where your patient's urinating and you apply a little bit of pressure over the bladder area to help evacuate the remaining urine that's in there. They may need to be on a bowel training program where, again, they're trying to move their bowels on a daily basis, typically after breakfast in the morning in a sitting position will help facilitate that. And dietary modifications to help with the bowels, increase fluids, increase fiber as much as possible. For aspiration precautions and nutrition, we get concerned about this because as they get muscle weakness and have difficulty swallowing, they have that risk for aspiration. So of course, your basic aspiration precautions, sitting upright, small bites, swallowing one bite at a time, very important. To really promote nutrition in these patients, you want to go with a low-fat, gluten-free diet. Some of the newer research that we have with MS is showing that when they're on a gluten-free diet, their symptoms tend to improve slightly. So that's something to keep in mind. High fiber to deal with that constipation, and high protein. You really want to maximize the calories that they're taking in. They may require supplemental vitamins. From a safety perspective, you want to reduce risk for falls and injury. We kind of mentioned this a little bit before with the collaborative team, the use of assistive devices and home modifications. As their disease progresses and they have more weakness, we worry about immobility and complications related to immobility. DVTs, atelectasis, pneumonia, just muscle atrophy and wasting. We really want to keep them functional. So, things such as the PT, the OT, active range of motion exercises, passive range of motion exercises, those are pretty important. From a psychosocial perspective, I just want to add a few comments with this. It's a chronic progressive disease. And when you think about who is at risk and when it tends to strike people, females between the age of 20 and 40, um, you think about Erickson's and what they're supposed to be doing during that time. They're establishing their life, they're building a career, they're raising a family. And that really takes a toll on them. I had a close friend from grade school whose mom was diagnosed with MS when we were in third grade. And by sixth grade, she was in a walker. And by ninth grade, she was in a wheelchair. And she just made it to our high school graduation, and she passed shortly after that. But from a psychosocial perspective, that was huge for her because she was trying to deal with this disease process that was impacting her daily life and thinking about how this also affects her children, how this affected her spouse. And, my mom was close friends with her as well. And, I was talking with my mom years later, she had said how my friend's mom confided in her that, she was embarrassed at times to go to the school because she felt bad for her son because his mom's the one with the walker or his mom's the one with the wheelchair. And, wanting to attend his soft baseball games, attend the band concerts, doing all those things. So it really creates some psychosocial angst there. So really looking at the patient and making sure you're addressing all those areas to meet their needs. And finally, talking about avoiding and minimizing exposure to triggers. That is a critical piece of disease management for MS. Okay, switching gears to myasthenia gravis. This is also an autoimmune disorder. It is progressive, but essentially it produces antibodies that attach to nerve receptors and it blocks impulses. Okay, so basically it's, it affects the acetylcholine. But basically these muscles are in constant stimulation. So think about a muscle twitch. It can only do that for so long before that muscle completely just stops functioning. Okay. Why is this a concern? Think about your biggest and most important muscle in your body, your diaphragm, that controls your breathing. Okay. So this can really turn into a problem. Myasthenia gravis is associated with other autoimmune disorders. It's not uncommon for a patient with one autoimmune disorder to have a second or third one. And it's also associated with hyperplasia of the thymus gland, not the thyroid gland, the thymus gland, okay? And that sits in your chest cavity underneath your breastbone, okay? Myasthenia gravis is also characterized by periods of exacerbation and remission. However, muscle weakness improves with rest. The difference you'll see with this is that rest makes a difference. So these patients tend to be the strongest in the morning. They'll get progressively weaker, but then when they rest, they gain back that strength. So when you think about management of this disease, they're going to experience some symptoms on a daily basis. So we want to control them. But with exacerbations, it can get really serious and impact their respiratory drive very quickly. So we really want to try to control the triggers. So your risk factors and your triggers are almost exactly the same as MS, okay? Smoking is also a further risk factor and trigger. So you want to make sure you're controlling those things to prevent an exacerbation, because these patients, when they have an exacerbation, can become deadly very quickly. So what are you going to see? They're going to have diplopia, very similar to MS. They will also have ptosis, or drooping of the eye. And you can see that in the picture on the screen. They're going to have muscle weakness. It can be generalized. We get most concern with facial and throat muscle weakness. just because of the risk for swallowing difficulty, aspiration, and how it can affect respiration. So they'll often experience dysphonia, where they have issues with their voice. The muscles may not be strong enough to get out a clear voice for them to be able to enunciate. Dysphagia, the swallowing issue, like we said, and then, of course, respiratory failure if we're having the diaphragm involved. So how do we diagnose this? Okay, it's not extremely common, but it's pretty serious. So they will do a diagnostic test. It's known as tensilon testing, but essentially they administer tensilon, and if it's positive, you're going to see an immediate improvement in their muscle strength. Just, it's almost like flipping on a light switch, okay? Now, a little goes a long way. So when they're testing, they're just giving a small amount to see. Sometimes even that is too much for your patient, and we might need to reverse that. So it is important that you know that atropine is the antidote for tensilon to kind of counteract that. Some other things that they can do, we have blood tests that look for antibodies that will destroy the acetylcholine. So if the blood test is positive for those antibodies, that supports a diagnosis of myasthenia gravis. They may also do an EMG. Now, if you remember about the EMG, which we talked about back in the musculoskeletal unit, it's pretty painful when they do this testing. But anyway, your results will show a decrease in the successive action potentials. MRI will often show an enlarged thymus gland. So how do we treat this? Medication, we're going to use cholinesterase inhibitors. These meds are going to inhibit the breakdown of acetylcholine, and as a result, it will increase their muscle strength. The common one that you will see given is your pyridostigmine. It's also known as Mestinon. Okay, so that will directly treat the symptoms. To actually treat the disease process, the production of those antibodies that destroy the acetylcholine, we'll use things such as immunomodulators or corticosteroids. Okay, they will be dosed daily. We're looking at a low dose consistently every day to try to suppress the production of those antibodies that destroy the acetylcholine. We may need to increase the dose of corticosteroids if your patient's having an acute exacerbation. Things that we need to think about, side effects, the leukopenia, okay? We're suppressing the immune system because it's attacking itself, it's producing these antibodies, but if we suppress it too much, we have that risk for infection. The other thing is a lot of your immunomodulators, they get metabolized through the liver, and we need to watch for any dysfunction in the liver. We may use intravenous immunoglobulin or IVIG. This is infused very similar to like an IV fluid, but it actually goes through the circulation and it binds to those antibodies. And once those antibodies are bound, they can't destroy the acetylcholine anymore. So sometimes that is used, usually on like a monthly basis. They may do plasmapheresis, which is similar to like a blood donation where they take your blood out. Okay, so they kind of take it out. It's cycling out, and it's like filtering the plasma. And the whole idea of this is it's going to remove those circulating antibodies. So that's an option. Usually IV, IG, and the plasmapheresis, those are not first-line treatments. That's more if the other stuff is not effective. And we need to add something else to it. There's also the option if the patient has the enlarged thymus gland, they can do the surgical removal of the thymus. So looking at management from a nursing and a collaborative standpoint, aspiration is a major concern. And also because they have muscle weakness, nutrition is going to come into play with that too. So it's very important that these patients rest prior to meals because they want to reduce muscle fatigue. They want to make sure they have the most strength to be able to eat their meals safely. You also want to time the meals with the medication peak. So they often take their meds multiple times a day, so the timing is critical in relation to their meal time. Aspiration precautions, definitely want to employ those. High calorie meals, easy to chew foods. We don't want these patients to expend more energy than they have to. You can give larger meals in the AM, smaller in the evening, because as their day goes on, they're going to get more and more weak throughout the day. And at some point, they may require supplementation, whether it's something oral, like, a boost, something that you can drink, Ensure, potentially to even enteral feeding. Something very critical to keep in mind is these patients need to let their dentist know about their condition, because if they use Novocaine, it will exacerbate their symptoms. So that is a critical point. You absolutely need to know that. From an energy conservation perspective, just like we're timing meals with the medication peak, you want to time activities with medication peak. Make sure you're scheduling frequent rest periods. You're assisting them with ADLs. I had the privilege as an instructor to actually interact with a patient who had myasthenia gravis many years ago. And it was with a foundation student. And at that level, they're just learning how to assess. They're talking to the patient. And they were sitting in there having a conversation. And it was neat to observe, because the patient said to the student, "I need to stop now. I have to rest so I can be able to eat at lunchtime." Okay. So really keeping in mind that, we want to interact with them. We want to build that, rapport with them, build that nurse-client relationship. But there are times you need to take your cue from the patient and may need to alter your approach. With eye care, it's not uncommon for these patients to have a little bit of what we call exophthalmos, where the eyeballs kind of pucker out just a little bit, and they have the muscle weakness of the eyelids. So sometimes the eyelids don't completely close, and which is kind of creepy when you see them like they're sleeping and you can see their eyes, partially open. But the other thing is, when your eyelid closes, that helps keep the eyeball lubricated. So we worry about drying out of the eye and potential damage to the cornea. So there are times, like at night, they may actually tape their eyelids closed. And regular use of artificial tears in the eye is going to be critical. We want to prevent any type of eye injury. And last, I just want to comment on a severe complication called myasthenic crisis. So you can have an exacerbation of symptoms, but when it gets to the exacerbation being so severe, it can result in respiratory failure. So most of the time, if this is going to occur in your patient, it's most commonly caused by an infection. So, good hand hygiene and infection prevention is really important, or if they're not receiving enough medication, okay, or their med dose needs to be adjusted. So what you're going to see with this is they're going to have generalized muscle weakness. Their cough will be inadequate. They'll have an impaired gag reflex. And that can cause secretions and aspiration, and they have weakening of the diaphragm, so you just don't have that respiratory effort, and it can result in respiratory failure. So what will happen is we'll diagnose it, they'll give that administration of Tensilon, we'll see that temporary improvement of the symptoms, but what you will see with this patient is if we're not aggressive in treating it, even though they're on the ventilator, they will not recover if we're not careful. So initially, we're putting them on the ventilator. We will use IVIG and plasmapheresis for this patient. Yes, we will use other medications, the cholinesterase inhibitors, but we initially need to remove those antibodies. We got to get the causative factor out of there very quickly. Okay, so we start with that, followed by cholinesterase inhibitors. Your respiratory therapy is a critical person in this plan of care. The patient will be vented, so we have to support that. We'll need to do chest physiotherapy, really loosen up those secretions, postural drainage to try to get that out. And because we're dealing with the respiration, we'll need to provide nutritional support for them because they're just not going to be able to take in at that point.